Welcome back to NSG4070 Legal and Ethics. I'm Professor Heather Murphy, and today we're going to connect values, moral development, and ethics directly to your NCLEX brain and your bedside brain.
And I'm Caitlin, your friendly neighborhood burn trauma nurse. If ethics has ever felt kind of floaty or philosophy class, hang with us. We're going to make it very clinical, very fast.
Let's start with a definition you can almost hear in an NCLEX STEM. Values are the ideals, beliefs, customs, ways of behaving, qualities, or goals that are highly prized by a person, a group, or a society. They give direction and meaning to life and quietly shape choices and behavior, even when we're not naming them out loud.
Then zoom into moral values. Those are the standards or principles we use to judge right and good versus wrong and bad. Moral values show up when there's an ethical issue. Do we continue aggressive treatment? Who do I advocate for first? What do I disclose right now?
Where do these values come from? Over time, your culture and ethnicity, your family stories, religion or spirituality, education, and just life experience. Some values stay pretty stable. Others shift after big events. Your first patient death, becoming a parent, maybe a medication error you learned from.
In the burn unit, I see clashes all the time. A family might have strong religious values about miracles and not giving up. My own values might lean toward comfort and pain relief. If I'm not aware of that, I'm just reacting from my gut instead of practicing professional nursing.
That's where self-awareness comes in. Self-awareness is ongoing self-knowledge, being honest about what you believe, where it came from, and how it colors what you see. Ethical relationships start there. If I don't know my own biases, I can't manage them.
Then we add values clarification. That's the process of becoming more conscious of and naming what we value. NCLEX tip. Values clarification is not the nurse telling patients what to value. It's helping them explore and choose their own values, instead of just running on habit or family pressure.
So when you see language like encourages the patient to explore, supports reflection, asks open-ended questions, that's values clarification, and it's directly tied to autonomy, the patient as primary decision maker.
Let's do a quick NCLEX style one. Listen for key phrases. A patient with terminal cancer says, "My family wants me to keep doing chemo, but I'm so tired. I just want to focus on comfort." The nurse's best response is A. You should follow your family's wishes because they will be caring for you. B. You sound conflicted. Can you tell me more about what is most important to you right now? C. Your oncologist knows what is best medically. Let's follow that plan. D. Let's ask your family to decide, since this affects them too.
Lock in your answer. The correct answer is B. It supports patient autonomy and values clarification. You sound conflicted. Tell me more. And what is most important to you are classic therapeutic phrases.
Notice what B does not do. It doesn't impose the nurse's values. It doesn't hand the decision to the family or provider. And it doesn't say, you should. It opens the door for the patient to clarify their own values.
So your NCLEX move when there's a values conflict, patient wants one thing, family or provider wants another, is to pick the option that respects patient autonomy and uses therapeutic communication to explore the patient's wishes, not direct them.
And avoid answers that push "you should" or automatically defer to family, unless the patient clearly lacks decision-making capacity. If they're oriented and expressing a preference, your job is to help them clarify and communicate it.
Let's zoom out to how people reason about these dilemmas. You don't need to memorize every stage number for NCLEX, but you should recognize patterns of moral development.
Think of it like a cheat sheet. We'll hit Piaget, Kohlberg, Gilligan, Fowler, and cultural developmental theory super fast. Pattern recognition only.
Piaget talks about cognitive development. Early thinking is concrete. Rules are rules. If I break the rule, I get in trouble. As people mature, they can handle abstract ideas and gray areas. So a patient might move from the doctor is always right to let's weigh risks and benefits.
Kohlberg focuses straight on moral reasoning. Early level, avoid punishment, get rewards. Middle level, be seen as good. follow rules to keep social order. Highest level, act from broad principles like justice and human rights, even when rules or expectations push the other way.
Gilligan reminds us many people, especially women, reason from an ethic of care, balancing care for others with care for self. It's not just follow the rule, it's what preserves relationships and minimizes harm.
Fowler looks at faith development, moving from simple, borrowed beliefs to a more personal, reflective faith. So a patient might shift from, this is what my family believes about illness, to, this is what I personally believe about suffering and healing.
Cultural developmental theory gives you three nice lenses: autonomy, individual rights and choices; community, duties to family, group, or society; and divinity, spiritual or religious obligations. On NCLEX, match the STEM's language to those key words instead of obsessing over which theorist it is.
Examples. My right to decide about my body screams autonomy. I don't want to shame my family leans community. It would go against my faith ties to divinity. You do not have to recite all the stages. Just recognize the pattern in the patient's reasoning.
Now, how does this feel on the unit? You'll run into intrinsic, extrinsic, and systemic value conflicts. Intrinsic is your internal sense. This patient needs more time to process what happened.
Extrinsic is the external stuff right in your face. I have 6 dressing changes. I'm behind on meds. I've got a new admit. Systemic is the larger structure. Policies, bed pressures, protocols. Like, we have to clear this bed for the next trauma. Real life is juggling all 3, all shift long.
When your moral values clash with those external or systemic restraints, you can experience moral distress. That's when you see what you believe is the ethically right action, but you can't do it because of staffing, policy, or pressure from others.
I remember a burn patient who clearly said they did not want more aggressive interventions. They were tired. They understood the prognosis. There was strong family pressure for everything, and system pressure to keep following the protocol. We kept doing painful procedures. I went home angry, frustrated, and honestly, a little numb. That's textbook moral distress.
If that goes unaddressed, it contributes to dissatisfaction, poor performance, and burnout. So, what can we do? One strategy is clarifying values with patients early, listening carefully, observing behavior, inviting questions and concerns before a crisis hits.
On the team side, debriefing after tough cases is huge. Just saying, that was hard, here's how I felt, with trusted colleagues. Ethics consults are another tool when there's real conflict about goals of care. And then advocacy, speaking up about patterns that keep causing distress. That's part of your moral agency as a nurse.
For NCLEX, if the STEM says the nurse feels anger, frustration, and is unable to act on what they believe is right due to institutional policy or family demands, they're pointing at moral distress. Strong answers involve seeking support, using institutional resources like an ethics consult, or advocating, not withdrawing or silently accepting it. Let's bring in Pender's health promotion model and tie all this back to culture, values, and NCLEX clues.
Pender is all about identifying the patient's values related to health beliefs and behaviors, then planning activities that fit those values. The goal is self-initiated changes that can lead to healthier lifestyles, not the nurse forcing perfect compliance.
So instead of, here's the ideal plan, just do it, you ask, what matters most to you? What do you believe about this illness? What feels realistic day to day? We align teaching and interventions with their culture, beliefs, and priorities.
NCLEX style scenario time. A 45-year-old with uncontrolled diabetes says, in my culture, refusing food from family is disrespectful. They bring me sweets to show love. The nurse feels distressed because blood sugars stay high despite education. Which action best reflects Pender's health promotion model and supports the nurse's moral agency? A. Firmly instruct the patient to refuse all sweets from family. B. Document non-adherence and notify the provider that the patient is not following the plan. C. Explore culturally acceptable ways for the family to show love that support healthier choices and include these in the care plan. D. Ask the charge nurse to assign a different nurse due to moral distress.
Think values and health behavior. The correct answer is C. It identifies the patient's cultural values and works with them to create a congruent plan.
Exactly. That's classic Pender. Understand what matters, love shown through food, then collaborate on safer ways to express that. Maybe different recipes, smaller portions, or alternative treats, but still honoring culture.
And notice how C also supports moral agency. Instead of staying stuck in distress, I'm watching harm and can't do anything, the nurse actively collaborates on a realistic, culturally sensitive plan.
Look at the wrong answers. A ignores culture and is super directive, not values clarification, not Pender. B labels the patient as non adherent without exploring barriers. D walks away from advocacy instead of engaging resources or the patient.
Let's land on some high-yield NCLEX takeaways. First, values versus moral values. Values are prized beliefs, qualities, and goals that guide behavior. Moral values are the standards for right and wrong that show up in ethical dilemmas.
Second, prioritize patient autonomy. When there's a family versus patient conflict and the patient has decision making capacity, choose responses that use therapeutic communication and values clarification. Tell me more. What's most important to you? Instead of you should or defaulting to family wishes.
Third, recognize moral distress. The nurse feels anger, frustration, maybe powerlessness, and can't act on what they believe is right because of policies, staffing, or pressure. Strong answers involve debriefing, ethics consults, and advocacy, not avoidance or blaming the patient.
And finally, remember Pender. Align teaching with the patient's values, culture, and daily reality. Ask what they believe, what they're ready to change, and build the plan with them, not for them.
This is exactly what moves you from just doing tasks to practicing as an ethical professional nurse, and what NCLEX is really testing when they ask about values, conflicts, and distress.
All right, friends, that's a wrap for today. Go practice spotting autonomy, values clarification, and moral distress in those practice questions.
Caitlin, thanks for bringing your burn trauma wisdom.
Anytime.
And thanks to all of you for listening. Keep growing that ethical nursing voice. We'll see you in the next episode.